Eating disorders and disturbances. Food is more than a source of nutrients. It is a source of pleasure and comfort, as well as an expression of love, prestige, power, or even control. Most of us take great pleasure in eating, and we can all admit to occasionally eating too much to the point of feeling uncomfortable and even stuffed. We also may have gone on a diet to get ready for swimsuit season, a wedding, or a job interview. But these behaviors are not considered an eating disorder, which is a persistent inability to eat in moderation. However, for someone with an eating disorder, food is a source of continual stress and anxiety. An eating disorder is a severe distortion of the eating process that jeopardizes physical and mental health. It can be life threatening and is a serious public health problem. Ideas about beauty and weight are determined largely by culture, and women are especially pressured to conform to these ideals. Overweight and obesity are considered beautiful in many non Western cultures, whereas Western cultures show preference for thin, gaunt women. However, for someone with an eating disorder, food is a source of continual stress and anxiety. An eating disorder is a severe distortion of the eating process that jeopardizes physical and mental health. It can be life threatening and is a serious public health problem. Ideas about beauty and weight are determined largely by culture, and women are especially pressured to conform to these ideals. Overweight and obesity Ideas about beauty and weight are determined largely by culture, and women are especially pressured to conform to these ideals. Overweight and obese individuals are considered beautiful in many non Western cultures, whereas Western culture show preference for thin, gaunt women. The average American woman whose dress size is a 12 or 14 is constantly bombarded with media images, fashion trends, and professional pressure to be thin. The continuum of eating. Eating exists on a continuum: healthy eating, problematic eating, and eating disorders. The fifth edition of the American Psychiatric Association's Diagnostic and Statistical Manual of Mental Disorders, or the DSM 5, has three distinct categories of eating disorders: anorexia nervosa, bulimia nervosa, and binge eating disorder. This diagram shows the eating disorder continuum. On the extreme end, we have self-starvation, and on the other end, we have compulsive overeating and binge eating disorder. And somewhere in the middle, we have bulimia nervosa and the binge and purge cycle. So, self-starvation exists at one end and compulsive overeating exists on the other end. So, what then is healthy eating? Eating a variety of foods, eating adequate amounts of food, eating without undue guilt or anxiety, eating regularly most of the time, and occasionally rewarding oneself with treats or comfort foods. On the other hand, there's problematic eating. There are recurring episodes of overeating, recurring episodes of undereating, recurring distress regarding body size, recurring negative comparisons of one's body to others, over-exercising to lose or maintain weight, and avoidance of categories of foods to avoid guilt, which can result in compromised nutrition. Anorexia nervosa. This involves weight loss, which usually occurs rapidly, restrictive eating, such as fasting or severe diets, dizziness or fainting spells, rigid exercise routines, intense fear of fat regardless of low weight, and self-worth that is determined by what has or has not been eating. Bulimia nervosa involves binging, secretive eating, vomiting, the use of laxatives and diet pills, fear of being fat regardless of weight, rigid, often excessive exercise routines, self-worth which is determined by what has or has not been eaten. Binge eating disorder involves repetitive episodes of eating rapidly far past the point of fullness, feeling tormented by eating patterns, restriction of activities due to embarrassment about weight, secretive eating due to embarrassment about quantity of food consumed. We will now look at each one in a little bit more depth. Binge eating disorder. Binge eating disorder was approved for inclusion in DSM-5 as its own category of eating disorder. Binge eating disorder is defined as recurring episodes of eating significantly more food in a short period of time than most people would eat under similar circumstances, with episodes marked by feelings of lack of control. Individuals with binge eating disorder often eat very quickly, even when they are not hungry. The person may have feelings of guilt, embarrassment, or disgust, and may binge eat alone to hide the behavior. This disorder is associated with marked distress and occurs on average at least once a week over 3 months. While overeating is a challenge for many Americans, recurrent binge eating is much less common, far more severe, and is associated with significant physical and psychological problems. Binge eating occurs in individuals with a wide range of eating habits and body sizes. Binge eaters exhibit many of the same characteristics as bulimic patients. However, unlike the bulimia sufferer, the person with binge eating disorder does not attempt to compensate by purging or by other means of getting rid of the food. Some may snack all day, eventually consuming an exceptionally large quantity of food. These individuals spend a lot of time thinking about food and have tried many weight loss diets. This pattern of overindulgence can be seen in people who restrict their food intake during the day at work or school, but binge eat at home. Essentially, food is used to fill an unmet emotional need. However, food cannot fill emotional emptiness. More than 50% of those who suffer from binge eating disorder have clinical depression. They also have feelings of depression, loneliness, anxiety, or stress, and these can precipitate a binge. Like other patients with eating disorders, those with binge eating disorder are all or nothing thinkers. They tend to categorize foods as safe or dangerous. Eating even a small serving of forbidden food can trigger a binge. Some of the health complications: overweight or obesity, type 2 diabetes, arthritis and joint pain, lipid abnormalities, increased blood pressure, chronic kidney problems, gastrointestinal problems, heart disease, gallbladder disease, and sleep apnea. Treatments for binge eating disorder include cognitive behavior therapy, interpersonal psychotherapy, self-help groups such as Overeaters Anonymous, which is a 12-step program, medical nutrition therapy with a registered dietitian nutritionist, practicing mindful eating, and antidepressants may be prescribed to reduce the urge to binge. Anorexia nervosa. Anorexia nervosa is an eating disorder characterized by self-induced starvation and excessive weight loss. Anorexia nervosa primarily affects adolescent girls and young women. It is characterized by distorted body image and excessive dieting that leads to severe weight loss with a pathological fear of becoming fat. It affects about 1 in 250 girls ages 12 to 18. Girls who develop anorexia usually do so around puberty. More than 90% of cases occur in women, and the death rate from anorexia is about 10 times the death rate of women without the disease. Self-worth is linked to their body appearance. Individuals who are diagnosed with anorexia don't lose their appetite until they are in the final stages of the disorder. They are obsessed with food, but their greatest obsession is with thinness. Anorexia is more prevalent in Western societies that have an abundance of food and an attitude that equates beauty, particularly feminine beauty, with thinness. 9 of 10 anorexia sufferers are female, and studies show that the peak age of onset is 15 to 19 years of age, and the typical anorexia sufferer is an upper-class white female adolescent. Anorexia may begin as dieting to lose weight. However, once the dieting begins, the person doesn't stop. There are long, rigid periods of semi-starvation and alternate periods of binge eating and purging. And the longer one suffers from anorexia, the poorer the chances of complete recovery. Anorexia sufferers tend to be rigid perfectionistic, all or nothing thinkers. Anorexia sufferers tend to be rigid, perfectionistic, all or nothing thinkers. They tend to lack a sense of independence and control over their own destiny and attempt to compensate for this through acts of intense self-discipline. Health complications: amenorrhea, or the cessation of menstrual cycle, abnormally slow and or irregular heartbeat, low blood pressure, iron deficiency anemia, poor circulation in hands and feet, muscle loss and weakness, including the heart, dehydration and kidney failure, edema or swelling, memory loss, disorientation, chronic constipation, growth of lanuga hair or baby fine hair, bone density loss, or osteoporosis. Successful treatment requires an interdisciplinary approach with a team consisting of a physician, psychologist, registered dietitian nutritionist, as well as psychological and other support staff. With intensive therapy, most patients can achieve a normal weight. However, they may struggle all their lives with a moderate to severe preoccupation with food and body weight, poor social relationships, and depression. The longer one suffers from anorexia before they receive treatment, the poorer the chances are for complete recovery. Therefore, the earlier a patient begins treatment, the better the prognosis. Bulimia nervosa. Bulimia nervosa is characterized by frequent episodes of binge eating, followed by inappropriate behavior such as self-induced vomiting to avoid weight gain. The DSM-5 criteria reduce the frequency of binge eating and compensatory behaviors that people with bulimia must exhibit to once a week from twice weekly as specified in the DSM-4. One to 3% of American adolescent and young adult females suffer from bulimia. And about 40% of college-age women occasionally binge and purge, which is often enough to raise concern, but sometimes too infrequently for an official diagnosis of bulimia. The average patient with bulimia is an unmarried white female in her 20s or 30s with a normal or near normal body weight. People with bulimia are also likely to binge drink and participate in other destructive behaviors. 50% suffer from clinical depression. Bulimia often goes undetected because people with bulimia are very secretive about their behaviors, limiting their binge and purge episodes to the middle of the night or times when they are assured of privacy. In addition, bulimia sufferers usually have body weights that are normal or slightly above normal. The triggers for a binge remain unclear. Individuals with bulimia tend to be all or nothing thinkers. For example, if they eat a cookie, they feel driven to consume the entire box. Hunger caused by very restrictive dieting and the buildup of stress often overwhelms the person's resolve and precipitates a binge. During a binge, individuals with bulimia typically consume massive quantities of food. Purging may be accompanied or replaced by fasting, excessive exercise, or other behaviors that compensate for the binge episode, such as the use of laxatives and enemas. Between binges, people with bulimia typically restrict their dietary intake to a limited number of low-calorie foods they consider safe. Health complications. Electrolyte imbalances that can lead to irregular heartbeat and seizures, tooth decay, edema or swelling, dehydration, vitamin and mineral deficiencies, gastrointestinal problems, irregular bowel movements and constipation, inflammation and rupture of the esophagus, tears in the lining of the stomach, and chronic kidney problems or failure. Little research has been done on the long-term course of bulimia. Bulimia, however, is easier to treat than anorexia, primarily because the patients recognize that their behavior as abnormal. Following treatment, about 30% of patients eventually become symptom-free. The rest, however, struggle with the disorder to some degree throughout their lives. Treatments for binge eating disorder include cognitive behavior therapy, interpersonal psychotherapy, self-help groups, medical nutrition therapy with a registered dietitian nutritionist, mindful eating, and antidepressants may be prescribed to reduce the urge to binge. Compulsive exercising. Compulsive exercise is exercise that interferes with important daily activities, occurs at inappropriate times, occurs in inappropriate settings, continues despite injury or other medical complications, and it is not currently a recognized clinical diagnosis in the DSM-5. Questions to ask a client: do you feel guilty if you miss your workout? Do you still exercise when you're sick or hurt? Would you miss going out with friends or spending time with family just to ensure you got your workout in? Do you freak out if you miss a workout? Do you calculate how much to exercise based on how much you eat? Do you have trouble sitting still because you're not burning calories? If you're unable to exercise, do you feel compelled to cut back what you eat that day? Do you experience intense anxiety, depression, irritability, feelings of guilt and or distress if unable to exercise? Do you maintain excessive, rigid exercise regimen despite weather, fatigue, illness, or injury? Do you experience discomfort with rest or inactivity? Do you exercise to manage emotions? Do you exercise a lot as a means to get rid of or burn off calories? Warning signs. Exercise as permission to eat. Exercise that is secretive or hidden. Feeling as though you're not good enough, fast enough, or not pushing hard enough during a period of excessive exercise or overtraining. Withdrawal from friends and family. Health consequences. Bone density loss, loss of menstrual cycle in women, female athlete triad in women, which usually involves the loss of health consequences. Bone density loss, loss of menstrual cycle, the female athlete triad in women, and relative energy density. Health consequences. Bone density loss, loss of menstrual cycle in women, the female athlete triad in female athletes, which involve the eating disorder, the loss of menstrual cycle, as well as bone loss, the relative energy deficiency in sports, or REDS, and this is similar to the female athlete triad relative to the symptoms. However, we recognize that males, especially male athletes, may also suffer. And so the relative energy deficiency in sports, that covers both male and female. Persistent muscle soreness and chronic bone, and joint pain. Increased incidence of injury, persistent fatigue and sluggishness, altered resting heart rate, increased frequency of illness and upper respiratory infections.